Good day, guys. So in this video, we'll study about the polycystic ovarian syndrome, PCOS. This is Dr. Rahul SM here. I'll guide you through the whole topic. So starting with the introduction or summary. So PCOS is the most common endocrine disorders in women of all reproductive age. So this is usually characterized by hyperandrogenism. So this is also known as teen-Leventhal syndrome. And PCOS is the most common cause of hirsutism, and many people think, there are many confusions that it could be idiopathic. But when it comes to hirsutism in the female, the most common disease which is suspected is PCOS. So coming to the pathophysiology of PCOS, the most obesity. So obesity is the most common risk factors because, as we know, the fat cells along with the adrenal glands, they secrete more estrogen. So because of increased peripheral estrogen synthesis from this adipose tissue, what happens is there is decreased sensitivity to insulin. So because of that, the patient has hyperinsulinemia. So they have the impaired glucose tolerance that can lead to diabetes as well. So because of this hyperinsulinemia, so we have this endometrial hyperplasia and hyperpigmentation. So there is increased androgen production in ovarian theca cells. So that is the reason the patient has hyperandrogenism. So there is because of increased estrogen, we know that there is increased luteinizing hormone secretion. So that disrupts that interrupts with the balance of luteinizing hormone as well as FSH in the ovary. So because of that, there is inhibition of this sex hormone binding globulin in the liver. So as we know, this sex hormone binding globulin that binds the free androgens and estrogens. So because of this inhibition, or because of the initiation, because of this inhibition, there is a increase of free androgens and estrogens. So because of this increased estrogen, it causes endometrial hyperplasia. As we know, the estrogen is responsible for the hyperplasia of endometrium. So there is a higher risk of endometrial carcinoma as well. So as we know, because of the increase of luteinizing hormone, these follicles, they don't mature. So because of this many immature follicles, this estrogen keeps on increasing, and there is decreased progesterone that leads to infertility, right? So next we'll study about the pathology of PCOS. So coming to the pathology, what are the pathological findings do we know? So the macroscopic findings show us the multiple brown cysts which are arranged in circular pattern in subscapular region of the ovary, and the cysts are approximately in same size. So this is the picture. So in this picture, we can find that the multiple brown cysts which are arranged in a circular pattern. So here you can find. So this is how the pathological findings are. And coming to the microscopic presentation, we can find the ovarian hypertrophy with thick capsule, and there is stromal hyperplasia and fibrosis as well. And because of PCOS, there is a decreased granulosa layer as well, right? So coming to the clinical features of PCOS, this PCOS usually occurs during adolescence. So because of which we have a menstrual irregularities. So this causes primary or secondary amenorrhea. It causes oligomenorrhea and menorrhagia and infertility as well. So as we discussed in pathophysiology, the patient has insulin resistance, because of which the patient gets metabolic syndrome such as obesity, and there is a risk of sleep apnea and non-alcoholic fatty liver disease as well. And coming to the skin conditions associated with the PCOS, we have hirsutism because of hyperandrogenism, and you have androgenic alopecia. Alopecia is the loss of hair, and you have acne, oily skin. And acanthosis nigricans is the most the gold standard marker for hyperinsulinemia. All right. And coming to the diagnostic features of diagnostic procedures of PCOS, we have this certain criteria called as the Rotterdam criteria. So speaking about the Rotterdam criteria, so we have the following triads called as the hyperandrogenism, oligoovulation, and enlarged polycystic ovary, the ultrasound findings of PCOS. So based on the presence of at least two of these following criteria, we diagnose PCOS. So coming to the ultrasound findings of PCOS, you can find that the ovarian volume is greater than or equal to 10 milliliters, and you find presence of multiple cysts which measures around 2 to 9 millimeter, and it appears like a string of pearls. So this is a ultrasound picture of PCOS, for instance. So this is how you find the PCOS ovary in ultrasound, right? So coming to the laboratory studies, we can evaluate certain values such as hyperandrogenism. You can evaluate the values of TSH and prolactin to rule out the differential diagnosis such as hyperprolactinemia or hyper or hypothyroidism. And also in PCOS, you can find that there is an overexpression of 17-hydroxyprogesterone as well. And for the patients with amenorrhea, you have to evaluate the serum or urine HCG in order to rule out pregnancy and rule out the values of luteinizing hormone as well as follicle stimulating hormone. And the consequences are diabetes mellitus, hypertension, and ovarian and endometrium cancer. And you can do transvaginal ultrasound. And for metabolic syndromes, you can find that the waist the measures over 35 inches and the triglycerides values are increased, the HDL values are also increased, and the blood pressure usually is more than 130 by 85 millimeters of mercury, and the fasting glucose values usually vary from 110 to 126 because of impaired glucose tolerance, right? And at least 3 or more risk factors of coronary artery diseases are also present, right? So now coming to the treatment of PCOS, the first line treatment we have to do is decrease lifestyle modification, so decreasing weight, so that even causes ovulation in 30% of the cases, so leading to 5 to 10% of body weight that increases insulin. So and also you have the metformin, which is the insulin sensitizer, so that also causes ovulation in 30% of the cases, but it's not used as a first line treatment. And we have a good drug called a clomiphene citrate. So use of clomiphene citrate induces ovulation in 80% of the cases. So clomiphene citrate is actually a hypothalamic E receptor blocker. So that causes secretion of high levels of a follicle stimulating hormone, so leading to follicular development. Usually the clomiphene citrate are recommended to take on the day 2nd to day 6th of the menstrual period, or from day 2 till day 6. So the common side effects of clomiphene citrate includes vasomotor flushing, headaches, and visual scotomas. And we have the drug called letrozole that can also be given. So the letrozole is chosen as the first line drug, first line treatment for PCOS. So these comes under the class called as aromatase inhibitors. So they inhibit the conversion of androgens to estrogens, and also they have less feedback, less negative feedback mechanism to hypothalamus, so that there is increase on release of follicle stimulating hormone. So comparing the clomiphene citrate with letrozole, that increases, letrozole has more advantages than clomiphene, as letrozole increases the birth rate. But in clomiphene citrate, there is an incidence of twinning around 8 to 10%. So, but in letrozole, there is a less chance of twinning, and you have better endometrial health and lesser anomalies and abortions as well, and lesser ovarian hyperstimulation syndrome as well, right? So coming to the irregular cycles, treatment of irregular cycles, we can provide the patient with combined oral contraceptive pills, progesterone pills, and in additional benefits, the oral contraceptive pills are additional benefits such as decreasing in endometrial hyperplasia and that decreases menstrual bleeding, and that decreases ache, and it's also used in the treatment of hirsutism. Usually the oral contraceptive pills are suggested for patients who wouldn't like to get pregnant, right? And also for you can treat the patients with anti-androgens such as spironolactone, which is the first line drug given for hyperandrogenism. And finally, coming to the surgical therapy, you can do laparoscopic ovarian drilling. So that laparoscopic ovarian drilling, they drill around 4 to 6 holes to the ovary. So that decreases the ovarian stroma. So as we know in PCOS, the ovarian stroma is thickened. So laparoscopic ovarian drilling decreases the ovarian stroma. So that induces better follicular growth. So It's all about PCOS. I hope you guys are clear about the whole topic. I will give you a heads up on the next video. Thank you for watching.